Good evening, everyone. Thank you for joining us. This is Ashkan Lashkari, your MOASC president. I wanted to introduce our monthly lung cancer webinar. Today we'll be discussing selective therapies for KRAS mutated non-small cell lung cancer, which, as you all know, is a rapidly evolving field where a couple of years ago we had no therapeutic options, and now we have two that are FDA approved. Just a few housekeeping issues. This is meant to be an interactive discussion. So if you have questions, please field them first into the chat room, and then we will bring them up and then engage our audience members in lively discussion. We are recording this event. So on that note, I want to introduce our moderator, Dr. Husain from UC San Diego, as well as our two panelist speakers, Dr. Mark Awad from Harvard University, from the Dana-Farber, and Dr. Velcheti, I believe from NYU, both thoracic oncology specialists and department leaders or division leaders within their area of specialty. Thank you for joining us. And Dr. Husain, I'll pass on the baton to you, and we can get started.
Thank you so much, Dr. Lashkari. And truly, it's really an honor and a pleasure to be able to be here with you all to talk about this topic. Dr. Mark Awad is truly a pioneer in actually, generating some of the data that we'll be discussing, and Dr. Velcheti as well, when it comes to selective KRAS G12C inhibitors. So it's really truly an honor and a pleasure to have them here to speak with us. So, again, this discussion is going to be quite tailored for the molecular subgroup of KRAS, and specifically the KRAS G12C mutations, largely because we have now FDA-approved therapies that are very specific for this subgroup of a patient. I think just some introductory slides, and then I'm going to frame some of our discussion in the context of a case, really to hear Dr. Awad and Dr. Velcheti's viewpoints on some of these characteristics. So again, this is built to be a conversation. And at any point, if there are questions or further areas of consideration, please do chime in. Throughout the discussion, I'll kind of frame certain questions for both Dr. Awad and Dr. Velcheti. So the first kind of major point is just to highlight that KRAS is not one mutation. There is diversity of different isoforms of KRAS. For here in lung cancer, we see that the most common isoform is the G12C mutation, and others are listed as well in their prevalence. I think it's also really important to note that this mutation really is an important mutation that is a transversion mutation that can really be the product of the carcinogen of tobacco. And we can see that in patients with former or current smoking histories, but 42% of patients, are noted in this subgroup of patients with KRAS mutations to have the G12C. So now let's kind of go into our patient case. So this is actually one of my patients, in whom is a 79-year-old who has had a right pleural effusion, a right-sided chest mass with chest pain, and brain metastases. She was found to have KRAS G12C. Also, on next-generation sequencing, had a tumor mutation burden of greater than 10, and a PD-L1 that was also elevated at 50%. Further characterization, there were other co-mutations that were identified, a P53 mutation and a KEAP1 mutation. And so initially, when we saw the patient proceeded with SRS to the brain lesions and at the time that this patient was started, pembrolizumab was really, the only agent that, that we had, and meaning the, the agent that was applicable. So the patient started with pembrolizumab monotherapy. May take a quick pause and say that, Dr. Awad has done, some really great work actually looking at the concept and prevalence of brain metastases among KRAS patients with G12C with a recent publication in JCO Precision Oncology. Dr. Awad, do you mind telling us a little bit about some of your findings from that paper? Specifically, noted was the prevalence, brain metastasis in the subgroup of patients. Some of your thoughts when you see a patient newly diagnosed with brain metastasis who has this mutation, how you think through some of the treatment options that may be applicable for them.
Thank you, Husain. I think, this is a very common case that, all of us are seeing in clinic, and there's really a lot to consider now in terms of choice of first-line therapies for this patient. And one of the exciting challenges for us now that we have, multiple treatment options is how do we predict what the best first-line therapy would be for this patient? So, currently outside of a clinical trial, the G12C inhibitors are approved for use in the second-line setting and beyond. So patients who have received prior systemic therapy for their lung cancer. So there are some first-line trials using G12C inhibitors upfront for the initial treatment of metastatic KRAS mutant lung cancer. We do think that brain metastases in lung cancer in general are of course, quite a problem, quite a challenge. Either at initial diagnosis or later during the patient's disease course. And the same is true for KRAS G12C mutant lung cancer. So when we looked at our own institutional experience or in collaboration with other institutions, it does seem that at initial diagnosis, brain metastases are fairly common for KRAS G12C. So probably up to 30% or 40% of patients may have brain metastases at metastatic diagnosis or upon further disease progression in the subsequent lines of after patients progress on standard therapies. So it is certainly a challenge. And I think what's been helpful, not just for KRAS, but for many molecular subsets of lung cancer, because because brain metastases are so common and problematic, is having dedicated and prospective untreated brain met cohorts in trials, so that we do learn about the CNS efficacy of our systemic therapies. So I think we have the most data from the Mirati inhibitor adagrasib, where they did have and presented some prospective data on patients with KRAS G12C mutant lung cancer and untreated brain metastases. And it seemed like the intracranial activity of adagrasib mirrored or closely matched what you would see in terms of systemic efficacy. So it did seem that some patients had very good CNS responses. I think with sotorasib, which was the first FDA approved KRAS G12C inhibitor, Amgen has been doing those studies to determine the CNS response rate. They're a little bit further behind in terms of getting the data out publicly. I think what we were interested in is this was prior to adagrasib's approval. We had some patients who had both systemic disease as well as brain metastases who received sotorasib. This was a very small subset of patients and a retrospective analysis, but we did see some intracranial responses to sotorasib as well. So I think we can see some good CNS efficacy with these drugs. It's I think that the cohort sizes are still relatively small, so it's always important to discuss how do we manage brain metastases when possible in a multidisciplinary fashion with radiation oncology and in some cases with neurosurgery. So I think there are a lot of options. I think right now, again, if this patient's not eligible for a first-line clinical trial, we would typically be using the G12C inhibitors as a second-line setting or beyond. And so here, for choice of first-line regimen, we would be discussing typically PD-1 monotherapy or PD-1 plus platinum doublet chemotherapy. And I think, happy to discuss some of the biomarkers that are shown here in terms of the PD-L1 level, the TMB, and the concurrent KEAP1 mutation, because they all have some impact on efficacy of these systemic therapies.
Yeah. No, thank you, Mark. Actually, super, that's a great introduction to this. I may ask you, Vamsi, as well, actually, from your institute, Josh Shabari actually kind of, presented that data with adagrasib in the brain. How has your experience been at NYU as well? Do you have patients actually that, you've really analyzed in terms of their brain CNS response, whether it be with sotorasib or adagrasib?
Yeah, so I was a co-author on that paper as well. So just as Mark was saying, I think it's just a matter of actually getting that data. Like I think Mirati had a cohort of untreated brain mets. So, they were untreated asymptomatic brain mets who were treated on the trial. The problem is Codebreak 100, we don't have any untreated patients who, at least the data that was presented so far, there was no patients who were untreated asymptomatic brain mets on the trial. So we don't really have a head-to-head comparison. So it's really hard to kind of conclude that one is better than the other in terms of CNS penetrance. As Mark was saying, of course, there's that retrospective data that's great. And also, we did present some data from Codebreak 100 on CNS progression-free survival at World Lung. I mean, of course, it's not quite the same, but the fact that there's some CNS control there, I think it's encouraging. And we just need to see more data. But again, I think we get caught up on the CNS penetrance of these drugs. But the truth is, it's not like EGFR or ALK. It's a very, very different setting that we're talking about. When we talk about a EGFR or ALK mutant tumor, we often don't pull the trigger in terms of radiation, unless they're symptomatic or they need SRS for a dominant brain lesion. So if somebody with KRAS has a brain met, I would actually not, I'd love to hear your thoughts, but I probably would just plan on radiating the lesions before starting systemic therapy. Especially in the frontline setting, definitely, obviously, it's not approved in the frontline. So that question of actually using a small molecule inhibitor just because they have CNS mets doesn't arise. I would do exactly what you did here, do SRF and save G12 inhibitors for second line.
No, thank you, Vamsi, for sharing those thoughts. Actually, so another point actually that I think interesting here at this juncture too is there are so this patient was started on monotherapy with pembrolizumab. There has been some recent data presented about certain subgroups from CTLA-4 and PD-1 combinations, particularly actually some data from the Poseidon study, in which the combination of durvalumab and tremelimumab plus chemotherapy, has gotten the FDA approval in the first line. Some of the subgroups actually with notable benefits actually have been the KRAS population, STK11. How do you view CTLA-4? Do you think actually that there is a unique differentiating component, thinking about some of these molecular biomarkers as we think through the right population for the integration of a dual checkpoint inhibitor in the first line?
No, I think the data is certainly intriguing. I've been kind of tempted to do that. It's just recently FDA approved, so I don't really have experience outside of a clinical trial to doing that yet. But if you actually look at the data, the patient, so it's not just a prognostic marker.
Sorry about no, sorry. I think why don't you continue? Actually, I think, yeah.
Yeah, so I was just saying, like, I mean, of course, STK11, KEAP1 are adverse prognostic markers, but in the trial, the patients who received dual checkpoint inhibitor did better in that population. So it seems to be predicting response to CTLA-4. I don't have a good biological explanation as to why that would be the case, but certainly I think it's an intriguing subset, and it would be reasonable to kind of use a dual checkpoint in that setting. We know that these patients do very poorly.
And Mark, what are your views on that? Actually, do you, how do you integrate CTLA-4? Do you integrate CTLA-4 for these KRAS mutant patients as well? What are your thoughts here on that point?
Yeah, thank you. These are really good questions, and they come up every day in clinic, and it's something that we discuss, that we debate. And I think you'll see, or we hear a lot of different management styles or differences in opinion. I think for me, I think the subset analyses are still a little bit small to really know which patient population is the right patient to consider incorporation of CTLA-4 inhibitors. We have, of course, now the CheckMate 9LA regimen of chemo plus ipi-nivo. We have the CheckMate 227 regimen of ipi-nivo. We have the Poseidon regimen of chemo plus durvalumab, tremelimumab. But what we don't have, in all of these trials, they were comparing these immunotherapy-containing regimens to chemotherapy alone. And what we don't really know is we don't have a good kind of clean prospective trial comparing, say, chemo plus PD-1 versus chemo plus PD-1 and CTLA-4, and enough patients with these different molecular alterations to know prospectively, does the addition of CTLA-4 to PD-1 and chemotherapy really make an important difference for patients, say, that are PD-L1 negative or that have a STK11 or KEAP1 co-mutation? To me, I think we just don't have those data yet. We do feel that there are some added toxicities to the addition of a CTLA-4 inhibitor with more immune-related adverse events such as colitis and other issues. So I think it's still in my mind a very open question, and for me personally, and I think at our institution at Dana-Farber, we don't tend to use a lot of CTLA-4 at this time, sort of pending some of the hopefully prospective data, just given some of the additional side effects, as well as, of course, financial considerations. But primarily, I think without sort of clear prospective data on, clear differential in efficacy, I think we're just not sure yet where to position these agents. So, but I agree, as Vamsi said, for this patient, the PD-L1 level is 50%, so we have the pembrolizumab monotherapy is approved, but we do think that there's a difference. This drug is approved as monotherapy, for PD-L1 50% or above based on the KEYNOTE-24 study, but we think that even higher levels of PD-L1, these patients do better. So a PD-L1 level of 95% is much better than 50%, even though we kind of clinically lump them into the same category. And I think same with TMB, even though it's not quite a biomarker that we tend to use to drive decision-making in lung cancer, at least. It does operate also sort of as a continuous biomarker. And I think in lung cancer, a TMB of 10 is probably too low to really differentiate improved outcomes to immunotherapy. I think there's some recent work that we and others have been doing showing that probably in lung cancer, a TMB closer to 19 or 20 mutations per megabase really is where you start seeing marked improvements in overall survival to immunotherapy. So it is challenging as to how to incorporate all of these different pieces of information to choose the best first line treatment plan. Again, the KEAP1 co-mutation also predicts for sort of worse outcomes to immunotherapy in this population. So,
no, well, thank you both. Actually, really great thoughts, and I think that particularly actually also kind of some of those last comments that some of those components of TMB and PD-L1 truly are continuous variables. And, really kind of citing both your work, actually looking at PD-L1 levels, whether it's greater than 90%, greater than, 70% or greater than 60% or 50%, one can really understand some of the implications across that continuous variable, as well as perhaps as you're suggesting with TMB as well. I think maybe a take-home point here is that in a KRAS mutant patient, this is a diverse patient population, even under the one molecular subgroup of G12C. And I think this really sets the stage for really understanding how does PD-L1 make a difference, how does TMB make a difference, how does some of these co-alterations, whether they be KEAP1, STK11, P53, ATM, some of these co-alterations can have some impact. And there's been a lot of work really looking and evaluating how co-alterations, can really help to at least prognosticate or understand some of the differences. Whether or not these are predictive differences, I think is being explored. And there are a number of trials that are trying to better characterize some elements of that. But I think through the discussion, we may touch on that point as well. So now when we move forward, so sorry about this, actually. The patient ultimately, got pembrolizumab for about a year and then had some progression on the immune therapy. And I think ultimately had some worsening pleural effusions as well. This was escalated with the addition of chemotherapy. I think we kind of touched on some of these points, with the role of immune therapy. I think one thing I will kind of make a comment of my experience with immune therapy in the G12C patient population is that I've been quite pleasantly surprised with how well patients can do with immune therapy. Some of my patients actually who are now 5 years out or plus, on monotherapy with pembrolizumab or PD-1 directed strategies, really are doing well for a long time. How has that been in your practice, actually? Are patients, would you say that, how would you kind of, if you were to kind of guesstimate how a patient could do on immune therapy, do you think the G12C patients are doing better than most? And maybe Vamsi, I'll start with you. Yeah. Mm-hmm.
Yes, in my experience, I think like it's the same thing. Like most of these patients are smokers, and typically do tend to respond to immunotherapy. But in my experience, KEAP1 patients, and especially if they keep on STK11 mutation co-alterations, I think those patients do very poorly. But if they don't have KEAP STK11 as marker for, they tend to do pretty reasonably okay.
And what about STK11 in that context? Actually, if you had KRAS and STK11 getting immune therapy, would you also think through perhaps a shorter time on the immune therapy?
Yeah, I agree. I think even those patients tend to have a shorter PFS, and that's a concern. And I think, I guess we'll get to this later, but obviously there are implications in terms of G12C inhibitors as well. So I think that's a little bit more complex subgrouping that we need to kind of strategize how to kind of bring these agents to the front line for those patients. I mean, of course, in clinical trial setting, it's not routine clinical practice, but that's an opportunity for moving the G12C inhibitors in the front line.
And before we move from this line, actually, just one last question is, in your practice, have you ever used a G12C inhibitor first line? And in which patients, would you consider that? No?
No, not off the clinical trial. It was only in the clinical trial context.
Okay. Mark, any patients that you have had the experience of a G12C inhibitor in the first line?
Yeah, it's a good question. I remember, there was some data presented from a retrospective analysis, or there was a study in Europe called the BFEST study, kind of looking at outcomes for patients with certain molecular alterations. And at the time, there was really no, in Europe, there was no KRAS directed therapy, but given some of the developing compounds for this subset of patients, they reported that for patients with KRAS G12C mutant lung cancer, maybe up to 20% of the patients never received any systemic therapy. So there are some patients that present late or due to comorbidities or age or other factors have a pretty poor performance status when you first meet them with a new diagnosis of metastatic lung cancer. So there have been a couple of cases where the PD-L1 level was low or negative, where I didn't think the patient could tolerate chemoimmunotherapy, but had a G12C mutation, where we have considered using, now that we have approvals, considered using a G12C inhibitor as the first line therapy, given that these are generally well tolerated. So there have been a couple of times where we've sort of appealed for the use of these agents in the first line setting, but typically we haven't done that outside of a clinical trial.
No, and I completely agree. In my practice as well, there's been some extenuating circumstances where some patients actually, could be served at least with some systemic therapy, and that would be in the context of a G12C. I'll give you an example. So I have a patient who has a dilated cardiomyopathy, who had a heart transplant, who, really had refused chemo, and immune therapy, could be contraindicated in her case. And so really kind of when you take those pillars of therapies away, what do we do? And in fact, actually, she was started on sotorasib, and now about a year plus out, really kind of with improvement in some of the symptomatology that she had. So I think that, there are extenuating circumstances where sometimes in the effort to provide some form of a therapy, there may be some options there. But again, those would have to be non-label type of approaches. So again, here is just some description of the available FDA-approved medicines. Again, sotorasib and adagrasib, this is just nomenclature of the chemical structures and such. And going forward, here is a three-dimensional view, actually, that was created by one of our students, who's actually on the call, Kevin Liu, who's on, who really kind of created these structures based on the chemical structure. Some important points is that the way that sotorasib and adagrasib work is by binding into the switch 2 pocket, and so kind of really affecting how KRAS oscillates. And as such, actually, one can think through, and this may be important, to think about how the medicine binds, where there can be potentially mechanisms of resistance or ways that the medicine may have some vulnerabilities. So this is also, just some information, some data also created by Kevin on the call, who, kind of based on an oncoprint from TCGA and other sources, kind of really looking at co-alterations. Again, we can see that P53 can occur in about 35%, STK11 about 30%, KEAP1 about 23%. There can be other alterations within the MAP kinase pathway, cell cycle pathway, and PI3 kinase pathways as well. So now let's go into some of the clinical data for some of the selective inhibitors. And again, some of the earlier data, again, going through this journey, it appeared somewhat piecemeal as data had come in. This is an earlier data, cutoff, but gauge from Codebreak 100, looking at patients who received sotorasib. And again, some of the key points to think through here are response, duration of response, PFS, and now in overall survival. Some key points is that patients were included after immune therapy and or chemotherapy and immune therapy. Number of patients actually had received several prior lines of therapy. In this case, actually about 20% had received 3 prior lines of a therapy. So here, shows the response rate at that cutoff, 37%, disease control rate, 80%, duration of response, 11 months. Time to first response was 1.35 months. Here is data is published in the New England Journal of Medicine. Again, 37.1% response rate, and the duration, 11.1 months. We can see from the swimmer's plot actually that many patients had their first response early, and then actually patients really stayed on medicine for periods of time. We'll actually take a quick pause here and say some things actually that have been discussed is the subsequent therapies, and also Mark, any other thoughts that you have as you think through some of how we evaluate response rate, the duration of response, other things that perhaps kind of could color this perspective a little bit better? And then we'll get into overall survival as well.
Yeah, thank you, Hatem. I think certainly these agents have had a major impact on our patients and on the field in drug development for KRAS. And as was mentioned, this has been a known driver for decades in lung cancer and other tumor types without any specific targeted therapies. So, here we're seeing in this initial study, or as you said, a response rate of about 37%, which is excellent for this molecular subtype of cancer for which we had no targeted therapies in the past. I think in lung cancer we've of course gotten spoiled a bit, or used to seeing higher targeted therapy response rates for as Dr. Velcheti, as Vanzi was saying, for EGFR, ALK, ROS1, RET, and others, and Dr. Velcheti's been a pioneer in some of these pivotal studies. But typically, seeing response rates of 60, 70% or even higher, and long progression-free survival numbers and duration of response. So, I think relative to those examples, that this is more modest efficacy. I think what hasn't been as clear is, how do we understand who are the patients that do better or worse? Who are the patients that have a prolonged response or a shorter benefit? That's some work that we're currently doing now that is in press, trying to understand what are the baseline features of patients with KRAS G12C mutant lung cancer that may impact the efficacy of these therapies. So I think it's certainly a huge step forward, and hopefully it's just the starting point of further drug development for this KRAS G12C population.
And I may just, take a quick pause just to ask you one quick point. So sotorasib was FDA approved based on response and duration of response. How do you view those efficacy endpoints? Do you feel like that's, sufficient and important enough, or do you feel like somehow PFS and OS and kind of the coloring of those data points kind of needs to be revisited or thought through, or any thoughts that you have on that point?
Yeah, it's an interesting question, as to how, especially how the FDA views different endpoints. And this comes up all the time, especially now that we have a number of trials in the perioperative setting and the neoadjuvant adjuvant setting, where sometimes we see these short-term endpoints reported out first. For neoadjuvant adjuvant trials, we're looking at things like pathologic complete response rate or event-free survival, disease-free survival after surgery, and are those endpoints good enough for approvals, or do we need to wait for overall survival? Can we have earlier endpoints or earlier readouts that serve as proxies for long-term benefit? So I think with a very sort of specifically designed targeted therapy, such as sotorasib or adagrasib, in a molecularly selected population like a G12C mutation, I think response rate often is is a good endpoint for accelerated approval. This has come up where in some cases a molecular alteration is quite rare, so it would be very hard to do a randomized phase 3 study versus standard of care and wait the years of follow-up needed to demonstrate an overall survival benefit, and especially when it's clear that a drug has single agent activity in a molecularly defined population, it could be hard to accrue to a randomized such study against, let's say, a standard chemotherapy, for example, for ROS1 mutant lung cancer, or we can talk about RET rearranged lung cancers and others. But so I do think that that it makes sense that this was approved based on the response rate and the duration of response as an initial endpoint.
No, thank you. Thank you, Mark. And Vamsi, actually, any thoughts that you have about how one puts into context PFS and OS vis-a-vis the response and duration of response?
Yeah, I think the context is everything here, right? Like, I mean, for patients with G12C, we didn't really have any good treatment options. And we had our lousy docetaxel. That's all we had to offer patients, right? I mean, like in terms of safety and also efficacy, it certainly is better than docetaxel. So I do agree with Mark. I think like in this kind of a very targeted drug, it's a designer-made drug. So I think it makes sense to approve it. And remember, it's a conditional approval, right? And the goal is to get access for patients early. So, and of course, we have a randomized trial. I think you probably will talk about that, Codebreak 200, which, of course, it's met its primary endpoint. Again, you could argue, should it be PFS there as the primary endpoint? But the reality is, like, you will have to, once the drug is already FDA approved, patients will receive access to the drug post-progression on docetaxel. It's really hard to demonstrate overall survival benefit. So I think a PFS, I think, is a reasonable, endpoint in this context.
No, thank you for sharing. And just to provide that color for the Codebreak 200. So again, the Codebreak 2 study, the Codebreak 200 was a phase 3 study looking at sotorasib versus docetaxel, and basically included 345 patients. The PFS was 5.6 months with sotorasib versus 4.5 months in the docetaxel group. The overall survival was also evaluated, and the overall survival was 10.6 months in the sotorasib group. So I think along those lines, I think the key point here is to think through how these endpoints of PFS, OS, also kind of the comparator arm docetaxel, play out. So with that, actually, we'll move to, just some of these points over here. I think that in some of the earlier iterations, actually, the overall survival was a bit higher, 12.5 months. I think some key points actually to speak about now are just some of these subgroups. Mark had mentioned that the KEAP1 population does worse than some of the other subgroups. This is shown here based on response, with the KEAP1 patients doing worse than the STK11 or the P53 patients. Here's just a slide which speaks about some of the safety and some of the key safety signals to note. Again, diarrhea, nausea, transaminase increase, fatigue, vomiting, and rash were noted on here. Treatment discontinuation rate was 7.1%. So again, actually, just to kind of jump through here, we're going to kind of talk about this fact that there are some ongoing works really trying to tease out which subgroups may be differentially evaluated in the context of sotorasib. This is a SWOG study in the lung map looking at co-mutations within KRAS and how prospectively those patients could be evaluated for clinical outcomes. So just going to take a quick pause here, actually, to kind of talk about, some of this. May ask actually, and Mark, I may ask, your experience here. Obviously, at Dana-Farber, you may have access to some really interesting clinical trials looking at both sotorasib or other inhibitors. Firstly, how would you kind of describe your standard of care clinical experience with sotorasib? Does it mirror some of the clinical trial results and data? So that would be one question. And then next, actually, really be great to hear about some clinical trials or other things that you guys are working on at Dana-Farber that could provide some color also about where the field is moving.
Yeah, thank you. And this is a very fast-moving field, which is fortunate, for our patients to be able to explore many different options for KRAS mutant lung cancers. So I think generally sotorasib has been well tolerated for our patients. Not many of them have relatively few side effects, and I do think that we can see good benefit in many patients, but as has been reported in the trials, the duration of benefit has its limits, and this may be true of these drugs as a class. I think we hopefully will learn over time. As there are many KRAS G12C inhibitors in development from not only sotorasib and adagrasib, but from Genentech and from Lilly and from Novartis and others. One question is, are we kind of hitting a therapeutic ceiling with G12C inhibitor monotherapy with response rates in this 30-40% range and a median progression-free survival in the 5 to 6 month range? I think that's what we're seeing clinically with these drugs after approval also. So I think, again, it's a big step forward and offers a good, very good option for our patients, but it has its limits. It's not quite the efficacy that we see with other molecular subtypes of lung cancer. So I think it's a very good step forward, but hopefully we can continue to iterate on these initial advances. There are many trials that are combining G12C inhibitors with other agents. So some of them are in combination with immune checkpoint inhibitors, so trying to potentially position these targeted therapies, the G12C inhibitors, at the frontline setting with immunotherapy or with chemoimmunotherapy even. There are many small molecule combinations, for example, with other pathway protein inhibitors. So, for example, using SHP2 or SOS1 inhibitors, or downstream of KRAS using MEK inhibitors, for example. There are other efforts to add EGFR antibodies to G12C inhibitors, PI3 kinase inhibitors, so even CDK4/6 inhibitors. So there are many different combinations that are in clinic already or soon to be in clinic, as well as others on the way. So it is a fast-moving field, as you mentioned early in your presentation. And this is a very common alteration in lung cancer, G12C, but KRAS in general. And so it does reflect a very large patient population and who is in need of new therapies. And fortunately, there are many trials in development for this population.
Thank you, Mark. Vamsi, any thoughts you have on your standard of care experience versus clinical trial experience with the G12C inhibitors?
Yeah, I think it's largely comparable. We have a lot of trials, so haven't been using sotorasib single agent, interestingly, like a lot, because we have access to some of the trials that we're accruing to. But I've been speaking to a lot of our community docs in our network, and I think the experience has been mostly comparable. The one issue that I want to point out, though, is one thing that you should note, like for most of the clinical trials, you have like a washout period, which is kind of clearly defined. And, there's at least about 6 weeks of a gap from prior checkpoint inhibitor. But, it's again highly variable from practice to practice. But some of my network oncology colleagues who have been kind of experiencing like really increased rates of hepatotoxicity. What I've noticed is like, they've been getting like sotorasib almost concurrently with the previous pembro. So what happens is like, the patient might have like progression of disease, but, because it takes a while for them to get like authorization for sotorasib, they end up treating the patient with pembrolizumab beyond progression. And there's almost like a concurrent administration, which obviously we know from the data that was presented at World Lung last year, like, there's some increased risk for like adverse hepatotoxicity when you kind of combine these drugs. Mm-hmm. So you got to be cautious. I think giving at least 4 to 6 weeks from the last dosing of checkpoint, I think is important.
No, thank you for sharing that. And some of the data actually with the pairing of PD-1 plus sotorasib, has been one that has really made us think about what is the effective the most effective combination, but also one that has the best tolerability profile. You mentioned some of the aspects that have been discussed around hepatotoxicity, which can be higher in the combination group. So thank you. I wanted to also, spend a little bit of time actually now speaking about more recent FDA approval with adagrasib. Again, this is some data from the Crystal-1 study looking at adagrasib as it, was combined in different approaches, adagrasib alone, combination approaches, also looking at it in combination with EGFR-based approaches, both in lung as well as in colorectal cancer. Here is some of the demographic data from the phase 1 and phase 2 studies. Here is some data published middle of last year, looking at the response rate for adagrasib. See a response rate in the order of about 42% in this cohort, duration of response 8.5 months, median overall survival 12.6 months. The waterfall plot, swimmer's plot shown, again, waiting on additional studies comparing to docetaxel. Here it just shows a larger version of a waterfall plot from the phase 1 and 1B and phase 2 studies. Here is some data about the tolerability. I think, there is noted nausea, diarrhea, vomiting, fatigue, increased ALT, AST, decreased appetite, QTc prolongation, anemia noted. I may take a quick pause here and say, Mark and Buncier, can you make a quick comment about your experience, tolerability, specifically how you counsel patients regarding nausea, vomiting, any kind of prophylactic measures indicated there, kind of any tips for practicing oncologists with that regard?
Yeah, so I participated in the phase 1 trial for the adagrasib, and back then they had like they had a different formulation and like a smaller dose pills, and some of the nausea that's reported here, I think this is like all cohorts pooled. So I think it's a little higher because there were a lot of patients getting like the older formulation, taking multiple pills. So I think that I think is probably why. But having said that, definitely adagrasib is like BID dosing. Still, like we have like more pills, and compared to sotorasib, which is once a day dosing and less pills. So otherwise, I think the safety profile is very identical, and the QT prolongation is an issue. Especially because we know that like 5 years from now, we won't be talking about G12C inhibitors as a single agent. We'll be looking at combination-based strategies. And that combination is likely not going to be immunotherapy, at least that's what I feel. I guess we talk about the IO combination studies like Crystal 7. Looks, the efficacy standpoint, it seems little disappointing, and of course there are still some lingering questions around safety and tolerability of these drugs, so with combination with IO. So I think if you had to combine with other small molecule inhibitors, and I think the QT prolongation might potentially be a challenge.
No, it's great to hear your viewpoint. I've always wondered, though, that even in the first line, if the response rate, doesn't seem to or kind of we're still waiting to see how that looks. It always seemed like an attractive situation that if a patient was on a PD-1, even post-progression, what would the thinking be about adding a G12C under those circumstances? But again, all that is not carefully studied and needs further evaluation. Mark, any insights you have about the combination of PD-1 and the G12C inhibitors? Where you view that? Vamsi, I was interesting thought that you thought that was probably not the combination that would move forward. I always thought that perhaps that would be the combination, that would move forward. But, what do you think, Mark, kind of relative to some of the safety data that's been reported?
Yeah, this is where there may be some differentiation between existing or future drugs where it seemed like sotorasib in combination with pembrolizumab or atezolizumab was too toxic with high rates of high-grade hepatitis. Mirati has reported some data recently of adagrasib plus pembrolizumab in about over 70 patients. And again, it's still early, but it seemed like, at least in the initial reporting, there weren't quite as high-grade toxicities, so potentially a path forward for combinations and some of these other drugs that are not yet approved. Other G12C inhibitors are also exploring immunotherapy combinations. So there may be some differences between drugs as to which ones can safely be combined with immunotherapy. Of course, the next question, if safe, is there any either additive or synergistic benefit? I think that's to be determined.
No, super insightful. And I think I've heard some people kind of really debate, is the transaminase a class effect? Is it not a class effect? Are there certain agents that may be better pairers? I think, really awaiting future results there. So now, just in the last kind of, discussion points, actually, I wanted to spend a little bit of time now that we've treated patients with some of these G12C inhibitors. Kind of what we're projecting and seeing is kind of some of the mechanisms of resistance or kind of ways, Mark, this is actually from your paper, actually, that, I thought was actually a very, very interesting paper looking at some of the mechanisms of resistance to, and in this context, it was adagrasib, but looking at some second site mutations to G12C. When Kevin, who was on this call, kind of created those crystal structures, it was really interesting to see how, some of like the H95 and the Y96, from your paper, were described. Here is one case that you presented in your paper. Here is some additional work, both across lung as well as colorectal. I think some points that were presented in the paper were just some of the mutational heterogeneity that can be seen. But Mark, any additional points you can tell us about your experience, perhaps other trials? And I'm aware of some of the trials that you're looking at, registry-based studies that can, really kind of, other people can participate in and kind of, help to support the effort to figure out the best strategies forward for patients.
Yeah, thank you so much. And I think, as we were putting patients on these trials and seeing them develop resistance, we were trying to obtain repeat biopsies as well as plasma to understand the mechanisms of resistance. And it was quite humbling, I'll say, or a bit daunting in terms of thinking about strategies to overcome resistance with subsequent therapies, because as you highlighted, many of the patients have multiple concurrent resistance mechanisms emerging simultaneously, especially when we looked at plasma samples. And so some patients have acquired second site KRAS mutations in that switch II binding pocket that you and Kevin showed earlier as to where these drugs bind. So the R68, H95, Y96 mutations. We saw other activating mutations on the other KRAS allele, so occurring in trans or in cis, and then a number of acquired, for example, MEK mutations, which or BRAF mutations, a number of fusions in ALK, FGFR, BRAF, and RET, and others. So what we're trying to understand is, are the resistance mechanisms different according to the drug? So, do you see a different spectrum to sotorasib versus adagrasib or others? Do they differ by the tumor type? Do you see more fusions, like as this graph might indicate in colorectal cancers than in lung cancer? They differ by combination therapy, monotherapy. So we just opened a study which everyone can participate in across the country. It's a remote plasma collection protocol called SPARC. So if you Google SPARC KRAS resistance, so if you have a patient on a KRAS inhibitor who is developing resistance, you can email me, or it's on clinicaltrials.gov. It has the contact information. And we do remote consent with the patient. We'll send them a blood collection kit within a few days, and they can go to any phlebotomist or their clinic, or we can arrange remote phlebotomy to collect blood. And we provide a free Foundation Medicine, Foundation One liquid next generation sequencing report that we provide to the treating oncologist as well as to the patient. And so I think this is something we're hoping will increase the numbers so that we can really get a sense of, are we going to see recurrent resistance mechanisms to certain drugs or within certain tumor types that will hopefully lead to future drug development? I think what we found in this initial report is that some patients also have histologic transformation from lung adenocarcinoma to lung squamous cell carcinoma. Of course, that's not something that you can tell with plasma today. So that highlights the need for potential repeat biopsies in addition to potential plasma sequencing. So, some of these alterations are potentially targetable, but we don't yet have examples from the literature of finding a resistance mutation that you can then target, say, by adding a second drug or switching to a different drug. But hopefully we'll learn more along the way. So for anyone on the call that has more questions, feel free to email me and or let me know about any patients where this may be helpful.
No, thank you so much, Mark, for really offering that up. Really kind of the prospect of creating an opportunity where people can participate who have patients on these medicines to really help move the field forward about the mechanisms of resistance is really great. So, and just speaking to your one point about the fact that, there is perhaps at least preclinically different efficacy that can be ascertained depending on the co-alterations, or the acquired second site KRAS mutations that can be seen. So we'll have to see how clinically such type scenarios play out. So with that, actually, I wanted to firstly thank you both for participating. I wanted to kind of just take a final moment actually and see if any any of the participants on the call had any questions for Dr. Velcheti or Dr. Awad specifically. I believe that there was a question that had come in about sequencing for IOs. Vamsi, thank you so much for sharing your thoughts specifically there about, when to, integrate. I think you had commented that you like to advise people about 4 to 6 weeks afterwards. This is really bringing up some stark remembrances in the EGFR, space where PD-1 and then an EGFR inhibitor, specifically osimertinib, there can be higher rates of pneumonitis, that type of loss. We'll have to see how this plays out. But it is curious from some of the G12s, I really made a specific point to target that these patients had been pre-treated with IO. Now, really understanding that time frame is something to think through. Just to speak to that point, Mark, do you advise patients about a specific time to hold off until you get started on the G12C inhibitor from last PD-1 use? Do you advise people on that point?
Yeah, it's a good question. I think sometimes your hands are tied a bit, and you don't have too many other options to kind of delay therapy. So I think this is something we're trying to learn more about as to, is there a safe window after which you can sequence immunotherapy and then the G12C inhibitors. I think for other targeted therapies, sometimes we like to have 3 months between immunotherapy and, say, an EGFR inhibitor or other TKIs, but I think it's not. Sometimes you just have to move on to the G12C inhibitor and really monitor closely for toxicities. So.
Well, with that, actually, definitely, thank you so much for participating. Thank you so much, actually, for those who have attended. Also want to thank our sponsors, which were Amgen and AstraZeneca, for this symposium. And Dr. Lashkari, I'll turn it over to you for the final words.
Thank you so much. I learned a great deal from both our panelists, Dr. Awad and Dr. Velcheti, and from you, Dr. Hatim. This was a wonderful discussion. Thank you so much for joining us. And Dr. Awad has listed his email address to learn more about the SPARK trial, which sounds like a wonderful opportunity for patients and their treating oncologists around the country to participate in. So on that note, we will see you next month, and appreciate everyone's attendance tonight. Take care. Bye-bye.
Thank you.